Hi, so today's lecture is going to be on diabetic drugs. So, the drugs that we prescribe in diabetes. And before understanding something related to the drugs, I want to just clear the normal physiology of the drug. So, what happens is that, let's say, when you're eating food, okay, this is your GI tract, and this is your enterocyte, okay? This is your enterocyte, all right? And while you're eating, what happens is that, let's say, you've had certain amount of food inside, all right, and the food you've ingested the food, it's broken down into glucose. So let me just write glucose instead of food. What happens is that your intestine is going to obviously absorb it. Now there are sodium glucose transporters, you know about SGLT. So what happens is that every time the glucose enters your enterocyte, every time your glucose enters your enterocyte, it stimulates the release of a hormone. It stimulates the release of a hormone called GLP. All right. So this GLP, glucagon-like peptide, if we call it, what it does is that it is first of all, what it does is that it inhibits gastric emptying. Gastric emptying. All right. And second, what it does is that it also stimulates the beta cells of the pancreas, and it stimulates the release of insulin and amylin. Now, what does this amylin do? Well, this amylin, it does pretty much the same thing, is that it inhibits gastric emptying. It literally does the same thing. So, in a nutshell, you take in food, your food, your glucose is absorbed in the enterocyte. The enterocyte is like, okay, fine, we'll release a hormone called glucagon-like peptide, GLP-1. This GLP-1 enters, and obviously it stimulates beta cells of pancreas to release certain amount of insulin. Okay, this insulin is minute. All right. What is more important is that this GLP is metabolized by something called as a DPP4. All right. It's metabolized by DPP4 in plasma because obviously it's in blood, and it's therefore metabolized. So therefore the GLP is a short acting molecule. Because there's a lot of DPP4, it's a short acting molecule. Simple as that. Now let me tell you about what happens when the glucose enters the bloodstream. Alright, this glucose has stimulated GLP4 release. Now let's say the glucose has entered into the capillaries. Alright, it's entered the capillaries, and then it reaches the pancreas. Alright, the glucose is present here, and it goes into the pancreas. Simple. And in the beta islet, this is the beta islet, the same beta islet that we spoke out here, the beta cell of the pancreas. So what it does is that this glucose enters and it produces ATP. This ATP is going to block the potassium channels. All right, they are going to block it. So what happens is that there is going to be release of insulin, and this release is going to be in a good enough amount, insulin and amylin. And this release is actually great enough to reduce the glucose level, to reduce the postprandial glucose level. All right, postprandial means after you've had food. So let's just look at the mechanism real quick. This is your beta cell. One way is there's a GLP receptor, there's GLP binds, there's going to be release of insulin. That's one thing. And there's going to be release of insulin. Let's say this is GLP bound. There's going to be insulin plus amylin plus peptide C, whatever you want to call it. Let me just write it in a better format. Insulin, amylin, peptide C. All right. So it goes there and it's going to cause its release. Simple. GLP. Now the other mechanism is that insulin it binds to this JAK-STAT tyrosine kinase receptor. All right. And what it does is, uh, completely my bad. This is exactly what happens when we are talking about an adipocyte or a muscle cell. Now, well, the GLP part is correct and it's true. It's pretty much true. What happens when, for the release of insulin on the beta islet cell, we've got glucose. All right, and it's simplest. Now what's gonna happen is pretty basic. What happens is that the glucose actually enters and it's converted to glucose phosphate by obviously hexokinase or glucokinase. Usually hexokinase, obviously. Now glucose phosphate is metabolized and we produced ATP out of it. Now here there are these potassium channel that are ATP sensitive. All right. So this ATP is going to inhibit these channels. Now the result is that there is no efflux of potassium, and the efflux of potassium decreases. And because the efflux of potassium decreases, the RMP, the resting membrane potential, that's at minus 90, shifts to minus 60 or at a higher point, which causes the cell to activate, or let's say the cell to release the insulin, and this insulin is released. So this is one way how insulin is released. All right. So that's why there are two things that we saw right now. One is insulin. So what does insulin actually do? It's actually so when insulin is released, insulin, what it does is that it increases the expression of GLUT4, and it's going to increase intake of glucose. Second, it's going to decrease gluconeogenesis. These are just basic functions that I'm stating. It's going to increase glycogenesis. It's going to decrease lipolysis. All right. It's going to increase amino acid uptake. In each and every sense, it's going to reduce the blood glucose. It has to reduce the blood glucose. All right. So that's one thing. Now the other things that we saw that are released, one is amylin and the other is GLP-1. GLP-1, it stimulates insulin release. Number one. That's its main function. Second is that it inhibits gastric emptying. Now, why is this gastric emptying inhibition so important? And what does amylin do? It too inhibits gastric emptying. Gastric emptying. Now, why is this gastric emptying so important? I mean, we all speak about it. We all want to know about why is it. So it's this simple. All right. It is really simple. What happens is that, let's say this is your GI and you have your stomach up more proximally. All right. So this is your GI and this is your duodenum. So if the emptying is reduced, most as in 90% of the absorption for glucose is actually in the intestine, where you don't really absorb anything of glucose in the stomach. Actually, the metabolism for glucose is not done in the stomach. Max, you have protein and lipid, a little bit of lipid absorption, metabolism and breakdown. So because glucose is absorbed here, most of it, all right, if the gastric emptying is decreased, the absorption of glucose is obviously severely decreased. And because glucose absorption is severely decreased, you will have a decrease in postprandial, that is after food, postprandial glucose level. That's perfect, isn't it? Now, one more important point that I wanted you to note actually, is that this glucose enters through GLUT1. Now remember, there are a few gluts like GLUT. It could be 1, 2, you have 1, 2, 3, you have 4, you have 5. 5 is for fructose. I remember that like that. 4 is the one that's insulin dependent. 1, 2 is obviously not dependent, present on RBC, brain, etc. So that's an important thing that you have to keep in mind for exams, because a question could directly come and stating that name the blood that is going to be uptaken that's going to increase in its amount, or probably is going to be expressed on the membrane if there is insulin. All right, if there's insulin, so you just need to note that, okay, glut is this, glut 4 is the answer. Okay, glut 2 is bidirectional, it's on beta cells of the pancreas, it's on liver. Even glut 1 is actually on the RBC. So actually I have made a mistake out here. This is going to be glut 2. Glut 1 is on RBCs, brain, cornea, placenta. 3 is also placenta and the fetus. All right. And glut 2 is on the beta cells and liver. Beta cell and liver. So I know it's a little shabby, but this is it. 4 is obviously on the adipocytes, even certain amount of muscles, striated muscles. And then we have SGLT 2 and 1. So SGLTs are the one that increase glucose absorption from the intestine. So SGLT 1 and 2. All right. Once this is done, all right, once this is done, we can talk about the drugs. All right, let's talk about the drugs. So once we've understood the very basic physiology, let's understand the drugs. So the categories of drugs for diabetes is that you could use first, we could do an alpha glucosidase inhibitor. This is one. The second one is GLP drugs. Under that, you could have a DPP4 inhibitor, because as I told you, the DPP4 causes its metabolism. So if we inhibit this, we will have increased levels of GLP. So actually, you know what? I'll just write it out here only. Glucose is converted, or let's say a disaccharide is converted to glucose by alpha glucosidase. So we'll use the color blue for all the drugs. All right. So if I inhibit this is going to be my alpha glucosidase inhibitor. So let's think about it. I have an alpha glucosidase, I'm going to inhibit it. What's going to happen? Obviously, your glucose level is going to drop. So your glucose level drops. Your glucose level drops severely. Your glucose level is dropping severely. So what you'll have is you'll have postprandial hypoglycemia. Out here. All right, you'll have postprandial hypoglycemia. What else will you have? You'll have disaccharides. So you might just have bloating. Okay, there'll be increase in starch. Okay, and there's going to be obviously flatulence. Okay, fair enough. So this is alpha glucosidase. Now let's talk about GLP agonists. Now let's focus on the GLP. One is you have GLP 1 agonist that directly stimulate the GLP receptors, or you have a DPP4 inhibitor. In both cases, what happens is that GLP is increased, or the effect of GLP is increased. So you will have increased insulin and you will decrease gastric emptying. So what happens is that you're going to have postprandial hypoglycemia. Correct. Isn't this correct? Okay. But when will this be effective? Will this be always effective? Well, this can be effective in all cases. Let's say DM1 and DM2. For that, you'll have to understand what is DM1 and what is DM2. DM2 is basically, DM1 is where you have decrease in beta cells of the pancreas. And DM2 is when there is increased resistance to insulin. So, if there's an increased resistance to insulin, increasing insulin probably might make a difference. It might make a difference. But in DM1, there is no beta cells. So GLP, if it is increased, the insulin secretion will not increase because there is no beta cells. GLP directly cannot induce secretion of insulin because beta cells of the pancreas are necessary. So we can definitely use this in only type 2 DM. I hope this is clear. Again, the same problem that you have with postprandial hypoglycemia is that you will have nausea, vomiting, stuff like that. Correct, because your GLP is increased. But will you have nausea, vomiting with a DPP4 inhibitor? No, you will not. Because of the fact that the DPP4 inhibitor is going to only increase it to a physiological amount. It's not going to increase GLP-1 to an extent that you cannot recover from it. You know, sometimes what we do is that we give medications and the GLP-1 agonist medications in such an amount that gastric emptying is very compromised. Let's say it's really reduced, and that leads to floating. But a DLP-4 is only going to increase it to physiological amounts. That physiological amounts can be a good amount to tackle diabetes, increase in physiological amounts. So therefore, it does not have bloating as such. All right, and then we have a very important drug that we saw. We saw a very important drug that's called amylin, right? So amylin is something that is also again going to inhibit the gastric emptying. So let's say if we do an amylin analog, all right, an amylin analog. Okay, so what will it cause? It will again cause postprandial hypo. But where are you going to use amylin? Well, see, now we do not really need amylin to stimulate. Amylin is not going to act directly on the beta cell. Rather, amylin analogs could actually our amylin is actually released from the beta cells. So let's say the beta cells are fired up in type 1 diabetes mellitus. Why do we need to worry? I mean, you have amylin synthetic analogs, you can directly plot. So you could use it in DM1 and DM2. Well, DM2 you would have to use it because there is insulin resistance. And the same side effects as postprandial hypoglycemia, nausea, vomiting. All right. Coming to the main hormone that we have, let's talk about insulin. All right. What about insulin? Well, you could use insulin in both. Can be used in DM1 and DM2. But there are side effects is that it can cause hypoglycemia. It can cause fat dystrophy on repeated use, but the side effects are comparatively lesser. But you do not want to give insulin again and again because it's an injectable. So we came up with oral hypoglycemic agents. What they do? Well, we've got 3 types of oral hypoglycemic agents. One is sulfonylurea. So what they do is that they block this potassium channel and they increase the insulin secretion. So what they do is that they increase insulin. So this is one oral hypoglycemic agent that we call as sulfonylureas. Actually, it has a class. The example is sulfonylurea. We'll dive into that in the next lecture. This is just something that we want to play around with this superb. We just want to mess this entire flowchart, right? We want to mess it up and we want to understand. We want to put the drugs here too, so that we understand it really well. Okay, so sulfonylurea is one. Now there's another oral hypoglycemic agent. What it does is that it decreases the insulin resistance. So we have an OHA that decreases insulin resistance. Well, that's one. And then we have an OHA, okay, that blocks gluconeogenesis. OHA that blocks gluconeogenesis. All right. So we'll go into those OHAs, oral hypoglycemic agents, individually. For now, let's keep this much in mind and let this be the first part of the lecture.